living longer, living healthier, living better than ever before. Welcome to Mountain Pacific's Healthy Living for Life, a weekly series that gives you the information, education, and expert insight you need to become an active participant in today's ever-changing healthcare climate. Here now is today's program host.
Inequity in healthcare and access to healthcare services costs thousands of lives each year. But what exactly is health equity and why is it so deadly? Welcome to Healthy Living for Life, a show dedicated to helping you do just that. I'm your host, Colleen Roylance, and today we're going to talk a little bit about health equity and why it's so important. Stay with us. We'll be right back. Welcome back. Joining us today is Deshane Barnett. Deshane is the Director and Health Officer for Missoula Public Health. Deshane, thanks so much for being here.
Thank you for having me.
Let's start off with some definitions.
Okay.
First of all, what is health equity?
So a lot of people tend to think of equality as a good thing. And so equality means that, we all get the same thing. If you get one of something, I get one of something. Equity is a little bit different in that, and especially when we look at health equity. So if we look at, say, doctor's appointments almost as a commodity, someone might have an illness where one doctor's appointment is all they need, and then they can, their illness is taken care of. Mm-hmm. Another person might have an illness where they need 8 or 10 doctor's appointments. Now, equality says, well, I gave you one, so I'm going to give them one. That means that one person has their needs entirely met, the other person does not. Equity says that you get out of the system what you need. So if you need one appointment, you get one appointment. If you need 8 appointments, you get 8 appointments. And so that's health equity, is the idea that we can actually get out of the healthcare system what we need. No more, no less.
So that's why equity is more important than equality.
Exactly.
Because of those personal differences.
Everybody is different. We are not all exactly the same. We don't have the same backgrounds, the same needs, and we need care that addresses us as a person.
Absolutely. So let's talk about health disparities. I hear about health disparities. So what is the difference between health disparities and health equity?
With a disparity, what you see is that there are a lot of different types of diseases. There's chronic disease, communicable disease, all kinds of diseases, and they don't affect every segment of the population the same. And populations can have different types of segments. We can have segments based on race, based on income, based on geography. And what we see with disparities is that somebody within a certain segment is being impacted by that disease greater than people in other parts of society. And what happens, especially when we think about what I just said with equality, is if the healthcare system is really designed to treat everybody equally, you're disadvantaging that entire segment of the population that's going to be more impacted by disease and illness than the rest of the society.
So you just mentioned racism, and I think back in April, the Centers for Disease Prevention and Control just declared racism a public health threat. And I know that there are different types of racism. So what are some of the different types of racism and how do they affect health equity?
Yeah, so broadly there's considered to be 4 types of racism, and you kind of can think of it as from very centered and then going out. So the first one is internalized racism, and that can actually show up in cases where we have in our country people who do not seek health care because they believe that either they shouldn't or that they won't get the care that they need, and they believe that not based on their condition or the science or anything like that. They believe that based on who they are as a person, and specifically their race or maybe their gender or other factors. And that internalized racism, so we're talking about racism, that internalized racism can actually keep people from seeking the care that they need. Then we have interpersonal racism, and interpersonal racism in healthcare, honestly, can be deadly. And that's why, we saw the call for racism as a public health concern. I'll give an example. I think it was last year, just north of us in Canada, there was an Indigenous woman who was at the ER complaining that she could not breathe, complaining that, of certain symptoms, and the nurses who were there and ignored this woman for hours and hours and hours. And, she at times would go up and she would, really try to get someone to pay attention to her. And she finally passed away. She expired in the waiting room from a heart attack. Whereas if that nurse had actually listened to her and taken her seriously, and it wasn't a nurse, but it was a few different nurses. But in that case, it was interpersonal racism. It was a white nurse looked at an Indigenous person and said, I don't believe you. I think you're faking because you're Native. I don't think that you have a real medical condition. And that was an interpersonal interaction.
That's a tragedy.
And unfortunately, that's not the only case. That's, I think, that one, got a lot of attention, but it's not the only example out there. Then we have institutional racism. And institutional racism, so then we're looking at, healthcare institutions and how they might treat people differently based on their race. And we have seen, where we have hospitals that you can honestly walk into a segment of the hospital and see, all of the people of color are here, and all of the non-Hispanic white people are over here and receiving different levels of care. So you've got, more doctors, more nurses on this side of the hospital. Inside, we're talking one institution. And so that institutionalized racism is when, as an entity, we treat people differently. And then we've got systemic racism, and that's honestly, it's the most powerful, most impactful, but it's also the hardest to fight. Because what that means is it's racism that is just ingrained in who we are as a culture and how all of our systems interact. And systemic racism is real, first of all. A lot of people don't believe it is. And it actually has damaging effects that are often ignored because it almost feels invisible, because it was the system when we like to look at the person. And so maybe that person wasn't doing something racist, but the system was racist and contributed to inequity.
It's a complex problem.
Absolutely.
Just as you've described it. So I want to talk a little bit more about health equity. We need to take just a short break. But when we come back, let's talk about some of the factors that contribute to health equity and how it relates to some of our historically underrepresented populations. We'll be right back. Stay with us. Welcome back. We're still talking with Deshane Barnett about health equity and how important it is. So you talked about institutional racism and health equity. And in my mind, that ties a little bit to another term I've heard, and that is social determinants of health. Can you talk to us a little bit about how social determinants of health can affect health equity? So
traditionally, what Western care has really thought of as medicine is, what's within the four walls of the exam room. We are growing beyond that to understand that most of what impacts a person's health actually takes place outside of the doctor's office. We learned that in some really hard ways. So, take diabetes, for example. We made some real strides in medicines and therapies, with insulin, metformin, all of these therapies, and yet people weren't getting better. And it's because even though we were giving them the medication in the doctor's office, we weren't supporting the health that needs to take place in the rest of their life. And so when we talk about social determinants of health, we're talking about, does a person's home environment, does their background, education, all of these things that can seem like they have nothing to do with health, but actually impact greatly on health, are those in a place where they're making that person more healthy or less healthy? And so, if you have someone who doesn't have stable housing, who doesn't have a good job, who doesn't have access to high quality health insurance, that person is not going to be as healthy as someone else who does. Even though a doctor, I can't prescribe you a job, I can't prescribe you health insurance, but those things actually impact your health. And that does relate absolutely back to institutional racism, because what we see is that if people of color are experiencing disparities in education, experiencing disparities in employment, experiencing disparities in housing, all of that is going to play back into their health. And so what we see then is that all of these broader policies that might seem at first glance to have nothing to do with health are actually what is keeping large segments of our population from attaining good health.
Yeah, so you mentioned Native Americans and or diabetes. You mentioned diabetes, and from what I understand is Native Americans are about 3 times more likely to have diabetes than the white population, and yet they have no access to health care. So what are some of the common barriers? And I think we're getting into some of those organizations, like you said, that are in the community. Maybe it's transportation, maybe it's food share. What are some of those organizations, and how can they help?
Well, and I think this is also a great place to plug. Community health is broader than just clinical care. And so when we look at the diabetes disparities within Native communities, there needs to be a community health approach. And so what happens is, so I'll give Missoula as an example. In Missoula, for years we have seen disparities in diabetes in our Native community. We partnered with the hospital. We got our patients enrolled in the diabetes prevention program and the diabetes self-management program. But what happens is that even though those are great programs, they're not designed for Native people and by Native people. And the patients just weren't getting the outcomes, the Native patients weren't getting the same level of outcomes that the non-Native patients were. So then we adapted the program and made it, more culturally specific. And what we saw is that then the Natives began to actually achieve the same outcomes from the program. And so it's not just that we need to have services available, it's that those services are more effective and cost us less if we, in the long run, if we deliver them in a way that's appropriate for the community that's experiencing the illness.
That makes sense, and it makes so much sense that it has to be culturally relevant and appropriate. One other thing that I've heard is that where you live, like your exact zip code, can have a bigger impact on your health than your genetics. So can you talk to us a little bit about that? I mean, that seems pretty focused.
Not just bigger. There was actually a study about 10 years ago that showed that your zip code is the single largest determining factor of your health status. And that is for a lot of reasons. Some of the things that I've talked about when we talk about racism, all the way from the internalized to the systemic. But there's a lot of reasons behind that. One, geography often can dictate your physical access to care. It can dictate your ability to keep yourself healthy. So think of if somebody is living, in a nice neighborhood that has really well cared for sidewalks and parks, they're going to get out and they're going to be active. They're going to go for walks and jogs versus somebody who lives in a neighborhood where in large urban areas, it could be, that it's dangerous. There's violence. In Montana, it's more that we in Missoula, we have many neighborhoods, what tend to be the lower socioeconomic neighborhoods that don't even have sidewalks. And so in order, including mine, so where I live is a historically lower socioeconomic neighborhood, and our house does not have a sidewalk in front of it. And so our 11-year-old son, in order for him to walk to school or to walk to the park, he has to walk on a street with traffic. And Obviously, I'm not going to be sending him out every day to go running and jogging, and that impacts on his health. And there's just so many other things around zip code, our tax investment. What we tend to do is, the people who are more visible taxpayers get more services. The people who are less visible get less services. And so your zip code can literally sometimes determine your life or death.
Wow, that is amazing, and really kind of comes down to why health equity matters to all of us.
Exactly.
All right, we need to take a quick break, and when we come back, we're going to talk a little bit about how we can close those health gaps and achieve health equity. Stay with us, we'll be right back. Welcome back to Healthy Living for Life. We are going to continue talking about health equity and the steps we can take to achieve it. So thank you, Deshane, for staying with us.
Absolutely.
Let's start with an example. So African Americans usually start smoking cigarettes later in life, and they don't smoke as many a day as white people. And yet, they are more likely to die of smoking-related diseases. So let's talk about how that happens and what steps do we take to reduce those numbers.
I'll admit it's a lot to unpack in just a few minutes, but I'll do my best. So when we're talking about health inequities, and especially when we're looking at systemic racism, what we see is that I might be an older white person who smokes, but I have very good healthcare insurance. I have very good insurance, so I get to go see my doctor 2-3 times a year. My doctor is prescribing me medications, probably trying to at least influence me to smoke less and or get exercise. And then there's that component is, as that more affluent person, even though I might be a smoker, I can go to the Whole Foods, the organic foods. I can buy really good foods. I can afford to go to the gym. Yeah, as a smoker, I might not be the world's fastest runner, but I can go to the gym and at least sit in the sauna a few days a week. And I'm doing other things that are still helping offset a little bit the impacts of my bad habit, the smoking. Whereas, as a African American, not all of those resources may be equal. And so, as an African American person who is, smoking but living in a low socioeconomic neighborhood, I might live in a food desert. I might not have access to any fresh fruit and vegetables. I might not have access to affordable physical fitness. And so even though you have two individuals who are smoking, they're not going to experience the same outcomes because of all of those other factors that come into play. And the others more, but.
Okay, well, let's talk a little bit about the community. So there's a program, the Racial and Ethnic Approaches to Community Health, or otherwise known as REACH.
Yeah.
Can you tell us a little bit about what that is and then how they work to decrease inequities?
So I mentioned in the last segment about how we culturally adapted the diabetes programming, and what we have found is that there used to be this idea that if there was no reason for us to put money into build a separate approach to providing care for someone who's African American versus someone who's white. We're all human beings. We're biologically the same, which means we don't need to do healthcare differently. And that's not true, because even though we're all human beings, we come from different backgrounds, different environments. And what we found is that when you adapt a person's care to be racially, ethnically tailored, we actually spend less money to make people well than if we try to do this one size fits all. And so, one example, we just talked about African Americans and smoking, but one example with Native Americans and smoking is that with our tobacco prevention program, what the traditional tobacco, and I always hate saying traditional because that means something else for natives. But when we look at the United States, the tobacco prevention programming has really focused around marketing and health education. Those commercials you see that the grandpa the kid walks through the ghost of the grandpa because he smoked, and it's supposed to tug your heartstrings. With the native community, what we've actually done is a return to ceremonial use of tobacco. That tobacco has had a long-standing role in the health and wellness of our communities, and it's different than commercial tobacco. And by teaching our young people and our adults about the role that tobacco actually plays in our community, then what we see is that they're less likely to then take up commercial smoking. Those are completely different approaches that achieve the same outcome, but in different ways.
That is absolutely fascinating. Thank you for sharing that example with us. So let's talk about, because we're talking about social determinants of health and we're talking about how we need to be culturally appropriate, what can we as community members do to help reduce inequity and achieve equity?
We, as a community, whether that's your city, your county, your local community, we have more influence over our neighbor's health than we probably realize. We need to be looking at what we can do to promote policies that allow everyone to have access to safe housing, affordable housing, to education, to employment, and we need to be promoting policies within our community that support those social determinants of health. And then at the same time also realize that if we want to really get the best bang for our buck, community health is a good investment. And getting outside the only approach to healthcare is a doctor and a hospital, and instead look at, for our community and specifically the segments in our community that might be experiencing health disparities, what can we do differently that could promote health within our community? And it might be something. So what we did in Missoula was we are actually undertaking an initiative to get sidewalks put in these lower socioeconomic status neighborhoods, and people might not think that that's immediately that's what we're doing to improve health, but it is. That's what we're doing to improve health, and it's something that took the involvement of more than just those individuals who are experiencing the disparity. We all had to get involved.
It's complex and it does take a village.
Exactly.
Duchesne, thank you so much for being with us. That's all the time we have for today. Keep up the good work. Thank you all for joining us, and I hope you'll join us again next week. And until then, stay fit, stay well, stay healthy for life with Healthy Living for Life. Thank you.
Healthy Living for Life is brought to you by Mountain Pacific Quality Health in partnership with AARP Montana. We'd love to hear from you. If you have suggestions for future programs, visit our website at mpqhf.org or call us at 406-443-4020. You can also catch us on YouTube by visiting our website and clicking on the Healthy Living for Life logo. Production facilities provided by Video Express Productions.